Pleasure to introduce Prof. Huang. He's the director of bone marrow transplantations of the first affiliated hospital at Zhejiang University School of Medicine. He's also director of Hematology Institute in the same universities. Prof. Huang specialties in clinical and basic research of stem cell transplantation and cellular therapy and stem cell biology. As a corresponding author, he has published over 330 original papers in highly impacted journals. For his outstanding achievement in stem cell transplantation, Prof. Huang was awarded the National Prize by State Counseling twice in 2003 and 2015. Prof. Huang will present to us ARMOD and NFI for next generation CAR-Ts. It's a pre-recorded session, but he'll be available for question.
Hello, everyone. And first, I'd like to thank you, Professor Aha and Professor Alaska invited me attending the SSBMT and the EBMT joint meeting. It's my great honor participating in this meeting. I'm Dr. Huang, come from the first affiliated hospital, Zhejiang University School of Medicine, Hangzhou, China. Today, my topic is armored and in vivo next generation CAR-T. It's my disclosure statement. We all know the main challenge in CAR-T therapy. We need the enhanced CAR-T because it's in clinical practice. We know there are some patients high resistant or relapse late, just like after the acute lymphocytic leukemia treatment, relapse about 60%. For no relapse and refractory non-Hodgkin lymphoma, complete remission just about 50%. So we need the enhanced function for CAR-T cell. Another point that because until now the individualized manufacturing induced clinical long time waiting and high cost. So I think that maybe we will need the more advanced manufacturing, just like in vivo CAR-T cell. So today we will focus on these 2 points. Future CAR-T development took in direction. How to modify engineering the CAR-T cell ex vivo, and how to develop the CAR-T cell in vivo. The generation of the CAR-T technology, we all know the first generation from Professor Ashha, and the second generation can be used in clinical practice and published by the Professor Michel Sedline. And now we will develop the 3rd generation and the 4th generation. So new generation CAR-T, the characteristic is cytokine expression or the armored, the track CAR-T cell. The taper of the armored CAR-T cell, one is the cytokine secreting armored CAR-T. CAR-T cells are engineered to constitute to inducibly secrete immunostimulated cytokine. Another second is a bispecific T-cell engager secreting CAR-T, just like the NK and the T cells are both activated and free loop. Another third is the checkpoint inhibitor secreting armored CAR-T. CAR-T cell secreted antibody fragment or the inhibited checkpoint that block immuno checkpoint locally. So there are some other ways, just like the chemokine receptor armored CAR-T, extracellular mixture modifying armored CAR-T, and inducible suicide genes armored CAR-T. Example of the armored CAR-T cell in clinical trial, and we all know here is there are some different cytokine secreting armored CAR-T, just like interleukin 15, interleukin 21, and interleukin 18, and focus on the solid tumor clinical trial and the hematological malignancies clinical trial. Cytokine armored CAR-T cell, effect of the cytokine secreted by the armored CAR-T cell on different taper of immune cell. virus cytokine demonstrated the ability to alert the immune cell phenotype in favor and a more robust anti-tumor response. This work published by Professor Hangzhou in New England Journal of Medicine enhanced the CAR T-cell therapy for lymphoma after previous failure. This product is human CAR T targeting CD19 and combined interleukin-18, an autologous anti-CD19 CAR T cell that constitutively secretes interleukin-18 with 4-1BB as a co-stimulated. It's manufactured in a rapid 3-day process that is designed to preserve stem cell-like characteristic and reduce exhaustion. Total infusion CAR T cell about 3 million. A total of 21 patients with refractory and relapsed disease were enrolled. One patient had previously failed commercially available CAR T cell manufacturing and was included in the study. The remaining 20 patients had either not respond or relapse after CAR T cell therapy. And 3 months after infusion, 81% of patients achieved either a complete or partial response, with 52% maintaining a complete response. The median follow-up time was 17.5 months, and the median duration of the response was 9.6 months. CAR T cell expansion detection was across all those cohorts during the 2 years follow-up period, and about the 75% patients remained detectable in peripheral. The CAR-T, CD19, and interleukin-18 product contain a high proportion of naive T cells compared to the previous anti-CD19 products. All the clinical trial or the study and interleukin-10 armored CAR T cell for refractory and relapsed diffuse large B-cell lymphoma. All the cooperated Professor Tang Li has published in Nature Immunology 2021. Interleukin-10 armored CAR T shows metabolically armored CAR enhanced metabolic activity, enhanced the proliferation and the cytotoxicity, enhanced the stem cell, anti-like anti-tumor memory. In vivo and in animal model and in feature, the study shows the lymphoma xenograft model and metabolically armored CD19 CAR T cell induce robust and durable tumor control. All clinical studies shows the eligible patients 18 and met CD19 and interleukin-10 manufacturing, and total is about 11 patients include all the study and allocated 4 doses. And we can see the ongoing expansion dose is very low dose. The ongoing follow-up. The safety analysis and the efficacy analysis shows is very low, just like about the 2.3 thousand per kilogram, responding to 0.1% dose of the commercial products. Leukapheresis can be replaced with the whole blood correction. For all the study shows complete remission, about 90%, overall response 100% for refractory and relapsed patients. CAR T cell expanded dramatically in all those, and we can detect in all the patients the peripheral blood, the CAR T expansion. A single cell analysis reveals that the interleukin-10 armored CAR T cell escaped upgraded expression of the effect gene, just like the and the FAST, and the INFNG, and the Stannis memory gene, SELL, and another genes compared with the conventional CD19 CAR T cell. For another point, we can see the armored CAR T can be inhibited as a checkpoint. This work in our group published 2 years ago, and no virus PD-1 integrated CAR T cell potentially eliminated the tumor cell. So such the patients, we use the CRISPR-Cas9 scan no virus and deliver this CAR gene, CAR structure into the PD-1, a high rate, 87.5% complete remission and durable response in clinical study, without grade 3 CIS or ICANS in 8 patients. And we can see such the actual medulla MS and can dramatically disappear after the CAR T therapy. RNA sequencing analysis indicated that anti-native expression of the inhibitor receptor shows its more efficacy in peripheral blood can be treated the diffuse large B-cell lymphoma. So another pathway is the bispecific killer cell engaging secreting CAR T cell. This work in our group published in Nature Biomedical Engineering this year, and we can see the bispecific killer cell engaging secreting CAR T cell directed nature killer specific to enhance anti-tumor response. Bispecific bicistronic expansion system to produce CAR T cell and CAR NK cell secreting responding ICEs. And so we call it the bispecific killer cell engaging secreting CAR T cell. CAR T cell and CAR NK cell secreting BiKey and BiTE into the culture media through the weekly and enzyme-linked immunosorbing assays shows its effective secreting. CAR T secreted BiKey and CAR NK secreted BiTE both had identical growth covers and the proliferative capacity with the unstimulated or antigen stimulated comparing with the common T cell or the CAR NK cell. Secretion of the ICE and no significant impact on CAR-mediated rinses of the target cell. In futures, we detect unimpaired function of CAR T cell and CAR NK cell secreting ICEs. Animal model shows the prominent efficacy of the BiKey secreting CAR T cell combined with the NK cell against B cell lymphoma and leukemia in mouse model. So we look forward to seeing this bispecific killer cell engaging secreting CAR T cell in clinical trial. The second point of this talk, and we will how to develop the CAR T cell in vivo. In vivo CAR T cell engineering, 2 kinds of the delivery system for in vivo CAR T engineering. One is the lentivirus delivery. So we will target the ligand, use genes, stings element, and another is targeted lipid nanoparticle delivery. So such the 2-pass delivery system, and we can see the intracellular mechanism and the expression kinetic in vivo CAR T engineering. Lentivirus system, we can see the target ligands and then the endocytosis, reverse transcription, genome integration, and the CAR expression suffers of T cell. is the durable CAR expression. Another pathway is the LMP, and we can see the target ligands as the mRNA in endocytosis and through the translation of the cell plasma and expression CAR structure suffers of the T cell. This is the transient CAR expression. Key advantage and limitation of the ex vivo and in vivo chemical antigen receptor T cells therapy technology. We can see there are some difference and advantage and limitation in vivo and ex vivo CAR T. In fact, there are many clinical trials ongoing in vivo CAR T cell. Here shows is about the viral delivery companion and just the Umoja, Interlulus, Ensobiotech, and there are some clinical study or the preclinical study ongoing. The CAR target about the CD19, CD22, CD20, or BCMA, and such the target. There are some many companies carry out clinical trial and no viral delivery companion, just like the Capstan, magic RNA, creatine area. So use the delivery system and the LMP, and we can see the target and the CAR about the CD19 and the CD22 or the BCMA and another TROP2. This is published in Lancet last year from the China group and the Tongji Hospital in Wuhan. In vivo B cell manufacture antigen B cell therapy for relapsed and refractory multiple myeloma. This system is a nanobody targeted immunoshield in lentivirus vector, and the engineering such as the modifying lentivirus, and total 4 patients, 5 treatment line of the 4 patients. We can see all the patients is refractory and relapsed multiple myeloma. The adverse events in the early and the late phase. So the 4 patients suffer from the CRS. One is grade 3 and two is grade 3 and 1 is grade 1 CRS. Another patient and have the hypertension and lymphodepression. This clinical efficacy analysis shows the extramedullary disease were all eradicated. After the PET-CT scan, after the CAR T therapy, day 28, we can see the extramedullary mass is disappear. It's all the group work. Also, we will ongoing the study lentivirus gene 2 viral expansion. Target lentivirus for treated for the lymphoma, non-Hodgkin lymphoma patients. This is the actual, we can see the in vivo animal model shows the efficacy for such the treatment. So these are patients, is Burkitt lymphoma, and we can see the such as before treatment and the burden and the baseline, and there's many mass and PET-CT scan shows is significant active medulla. And we can see after treatment and the CAR T peak value about the 151 and about the patients is reached the complete remission. The adverse events is grade 1 CRS and no ICANS. So the cytokine cover, we can see the copy number is reached the peak about the day 2012, and the serum cytokine levels, and we can see interleukin 6 is about the day 1 until about the day 17, the high level. So for another virus LMP system, and the first case come from China, Anhui Hospital, and the in vivo CAR T cell for SLE. In vivo CAR CD19 CAR therapy for refractory SLE patients. This work is carried out is the HM2301 is an engineering the CD8 the T cell target LMP encapsulating CD19 CAR mRNA. The scoring on the systemic lupus erythematosus disease activity index has decreased, indicating less disease activity in all 5 patients after treatment. CAR cell expanded in vivo peak at 7.33% of the circulating T cell on day 10. B cell aplasia persisted until month 5. Surrender 2K scoria reached 0 from month 2 onward. It's all the group data shows is the no virus, retrovirus, SLE treated the patients. And important in all the clinical study shows the patients an actually lymph node biopsy was performed on day 12. Histological analysis showed the disappearance of the lymph node follicles and the germinal center, replaced by dense CD3 positive T cell infiltration. Immunohistochemical staining for B cell lineage marker was entirely negative, confirming tissue level B cell clearance. So are the conclusion. Armored CAR T, especially cytokine armored CAR T cells, showed prominent efficacy and safety in hematological malignancies and low dose, and this approach may be extended to solid tumors. Lentivirus vector are engineering to directly transduce T cell in vivo with a sustained CAR expansion. Further application might focus on the malignancies. LMP deliver mRNA or sometimes the cryptocast components encoding CARs directed to T cell in vivo with the transient CAR expansion. Further application might emphasize no malignancies, just like autoimmune disease. So finally, I'd like to thank you for your invitation, and also thank you all the clinical team, Hematological Immunology Laboratory, international experts, all the cooperated by company, and thank you all patients and family. Thank you for your attention.
Thank you, Prof. Huang, for your excellent and elegant presentations. I think we have time for one question. I think he will join us.
Is he listening, and can we reach him? He's available now?
Yeah.
Dr. Huang?
Hi, hello. How nice to see you.
Yeah, this is Saeed from the Hematology Section and Transplant Unit of the old era, or the old-fashioned hematologists. Do you think the armor type of T cells can function optimally against the histocyte-rich, T-cell-rich, B-cell lymphoma if they are targeting CD19 only, or you have an additional armamentaria to help improve their efficacy against other lines other than CD19?
I think it is a very good question. Because of the targeted CD19 targeted CAR T, we have the measure used for the lymphoma and the leukemia. But we like to the challenge how about the just like the non-Hodgkin lymphoma some half patient is not reached complete remission. So I think the armored CAR use the cytokine with have the interleukin 18 or the interleukin 10 indicated as the enhanced function. I think the cytokine secreting can be the approved T cells proliferation and also can enhance the function of the CAR T cells just like leukemia and lymphoma. So all the clinical study issues is low dose, just like the 0.1% can achieve the complete remission. So we think that in future, just like the armored cytokine armored CAR T may be more efficacy in clinical practice.
Any more questions?
I have another question. If there is nobody to ask, I have another question. Do you think we need to apply the same principle of activating the T cells by transplanting non-specifically non-matched or fully mismatched T cells from an allo donor during the induction of patients with acute myeloid leukemia, like the old what you call it, leukapheresis transfusion protocol with AML induction therapy, so that you can induce an initial transient chimerism and little cytokine storm and targeting of the abnormal malignant cells by the transfused T cells. It's a principle proving experiment.
Oh, sorry. And would you like to repeat your question? Sorry.
The principle of armoring the T cells, but not from the same patients, from an allo donor during induction phases of acute myelogenous leukemia or any other leukemia, so that you can induce a form of a transient chimerism where the allogenetically or allogeneically transfused T cells may be able to induce a transient chimerism and some control of the malignant cells in the recipient.
Yeah, I think for the allogenic, now we will study such as cytokine as in armored CAR T in the autologous CAR T cells. And we also induce the allogenic CAR T and some the patients, and we will treat it as a SLE or the solid tumor. I think just like the strategy cytokine enhance function, and also can be used the allogenic CAR T cell. And in the SLE patient treatment, we don't use the lymphodepletion chemotherapy, just like the cytokine enhance the function. And for such the treatment, I think that also we can reach the complete remission. So in future, so I think the cytokine enhanced armored CAR T can be used the solid tumor, because it's the solid tumor we can overcome such as the barriers of the solid tissue, tumor tissue. So I think that in future, more and more patients can be used such as a strategy.
Thank you. Thank you for the answer. Any more questions? Thank you, Dr. Huang, for this comprehensive presentation and answering the question.